divided the GI tract into foregut, midgut, and hindgut. And we probably mentioned then, we didn't emphasize, that the foregut has a lot of large glands, digestive glands associated with it. The liver, the gallbladder, the pancreas, so that's going to be most of the content we deal with. But also in the oral cavity, we mentioned the parotid gland, submandibular, sublingual. We'll just show a little bit more about how they carry out their job, and then we'll go on and deal mostly with these glands associated directly with the foregut.
27, 20.
So the salivary glands, we mentioned there are three of them. The largest are the parotid glands, and they're back here just like situated in the space just posterior to the ramus of the mandible. You can't, they're not really evident unless they're, for some reason, taken out. Sometimes that will happen, and it really does change the profile of the face. But you can see, let's see, I better change the laser pointer so you can see it here. There we go. So you can see where the parotid gland is located here, and then you see this other one called the submandibular gland, and it does look like you should be able to palpate it, but it's never really all that evident. But it's just underneath and a little bit medial to the body of the mandible. And we'll see where that drains in. And then there are the smaller pair of glands called the sublingual glands. And we looked at when we were talking about the floor of the mouth, we saw a little fold under the tongue, which was created by the presence of these sublingual glands. So here's kind of like this. It's an old-fashioned drawing. This is what anatomy used to look like for fancy drawings and PowerPoints, but you can see an image of the green parotid gland posterior to the ramus of the mandible, just anterior to the auricle here. And then you see this duct running anteriorly, turning medially here, and piercing this muscle right here, which is buccinator muscle. So one of the muscles of facial expression, so you know that's innervated by which cranial nerve? I heard a 5. Did I hear? I heard a facial. What number would that be? Yeah, there we go. So this is this muscle is a muscle of facial expression, even though it's unusual in that it doesn't attach directly to the skin. Instead, it's just in our cheeks here. So the duct of the parotid gland is going to pierce that buccinator muscle, and then if you put your tongue on your cheek, way up here, you feel a little plica, like a fold of the mucosa. That's the site of the parotid duct entering the oral cavity. Okay, so well, I guess here we also have the submandibular gland, smaller than the parotid gland, and as I said, it has its location submandibular, right, just inferior to the body of the mandible. And its duct, we don't see it here because it's attached to the medial side of the submandibular gland, and it's going to run medial to the body of the mandible towards the floor of the oral cavity. And we looked at this picture before, and we were talking about this lingual frenulum that attaches to this mucosal fold that attaches the tongue to the floor of the mouth. But on that sublingual frenulum, there's this lump called a caruncle, a lingual, sublingual caruncle. And there are 2 openings there for each one for the submandibular gland on the left and right. So the duct of the submandibular gland is going to be beneath this mucosa right here, coming from the submandibular gland, running through to the caruncle and then opening directly into the floor of the mouth. And then here, just we talked about this before, we see this fold of tissue, or this little mound of tissue, that each mound on the right and left is covering the sublingual gland. And they don't have a main secretory duct, they have multiple small ducts that open directly onto the this fold of tissue and secrete directly into the floor of the mouth. So that's, those are the salivary glands. That's the anatomy of the salivary gland. So now let's go deal with the major part of what we're gonna be talking about today, and liver, gallbladder, and pancreas. So here we have our abdominal pelvic cavity. It's been opened up. We know the difference between that now and the peritoneal cavity. We're looking in at the greater sac that's been opened up because we've taken away the parietal peritoneum that lines the anterior abdominal wall. So we're looking into the greater sac. We see the greater omentum, the greater curvature of the stomach, and then of course the liver here, taking up its post mostly on the upper right side, right quadrant of the abdominal cavity, and situated right underneath the diaphragm, which is this right here. So we also see the gallbladder kind of peeking out from its the inferior surface or margin of the liver right here. We don't see the pancreas though, and then you probably remember we described the pancreas as retroperitoneal, which means it's attached directly to the posterior abdominal wall. So we would have to take out a lot of the viscera here in order to get to that pancreas. And here is our diagram where we've kind of stretched out a little bit of artistic license here. So we still see the liver in its normal place. We've taken away the diaphragm. But we see some tubes coming out of what's going to be called the visceral surface of the liver and attaching to the gallbladder here, which itself is attached to the liver. And then we see the ducts going on. They are, as we'll see, they're going to be attached to the duodenum. But before they get to the duodenum, they are going to receive a duct that is draining the pancreas right here. And the pancreas would be attached to the posterior abdominal wall here. So we'll go over the ductwork here, all the anatomy of that. That's going to be our main job. But this is where, this is basically the overview of what we're looking at. Yes, the other thing, as far as function goes, the liver has a huge number of metabolic functions. In fact, most of a biochemistry class is really all about what the liver is doing. I guess for when we're thinking of the digestive tract, though, one of the things we think about is bile. So bile is almost, you can almost think of it as a detergent, emulsifying agent that will break up dietary fat and allow the enzymes, lipases, for example, to break down the fat, and that allows the small intestine to absorb that as an energy source. So it's going to make bile. We already know, we talked about the portal venous system, so we know most of the venous drainage from the GI tract is going to go directly back to the liver before it goes to the heart. So all those hepatocytes or liver cells are going to have access to the absorbed nutrients. So the back to the liver making bile, the bile is going to be secreted from the liver through these ducts that we're looking at here, and it can be stored and even concentrated in the gallbladder. So that's the function of the gallbladder, to store and concentrate the bile and release it at appropriate times after a meal has been ingested. And then the pancreas, as I said, is retroperitoneal. It's both an exocrine gland and an endocrine gland. An exocrine is just meaning that it secretes material into a ductwork, and the ducts, the secretory ducts, then carry that product, in this case mostly digestive enzymes, to the appropriate target, in this case the duodenum. That's different from an endocrine gland, which in the case of the liver, it will make substances such as insulin, glucagon, that are released directly into the bloodstream. So there will be a rich capillary network around the endocrine cells in the pancreas, and those substances like insulin will be secreted from the cells that make the insulin. Will be taken up by the arterial system, the capillaries, and distributed throughout the body, as opposed to having a duct that will take it to where it needs to be. have just an overview of the peritoneal cavity and showing the relationships of the organs here that we're going to be talking about. So the pink is the greater sac of the peritoneal cavity. The blue is the lesser sac here that we talked about. But if we look at we imagine the parietal peritoneum lining the anterior abdominal wall here, we see it goes up, it reflects off the abdominal wall and goes onto the inferior surface of the liver. But then it reflects off of the liver and goes off of the diaphragm, it reflects off the diaphragm to attach to the liver and then surrounds the liver. And it's going to be, this peritoneum here is actually going to be continuous with a lesser omentum that's it's attached to the lesser curvature of the stomach and runs between the lesser curvature and the liver. So the liver is going to be referred to as intraperitoneal, even though it will have direct attachments to the diaphragm. And we'll talk a little bit more about that as we go. So it's intraperitoneal. The gallbladder would be the same. It would also be mostly covered by peritoneum. So if we look at the posterior abdominal wall here and follow the parietal peritoneum up here, we can see there it's going to reflect onto the mesentery proper, which is going to be, this is going to be the root of the mesentery, which goes out and covers the entire small intestine. But then here you see we're back on the posterior abdominal wall, and here is here's the a cross section through the pancreas. The pancreas is this elongated organ that sits attached to the posterior abdominal wall. We've made a section through it right here, and we can see that only its anterior surface is covered by peritoneum. So that's why we would call it retroperitoneal. The posterior surface is actually directly attached by connective tissue to the posterior abdominal wall. Okay, so here is, let's just take a closer look at the gallbladder and the pancreas and that ductwork that I mentioned that is draining the liver. So the liver is, as we're going to see, there are going to be two large anatomical lobes, and we're going to distinguish between anatomical lobes and functional lobes. But we see that there are two main ducts called hepatic ducts that are draining bile from the liver. So this is an exocrine function of the liver. So all the hepatocytes are making bile, secreting it into small channels within the liver, and you'll talk about them more in histology when you study that topic. But these small channels aggregate and form larger and larger channels, and there's a region on the inferior surface of the liver where two large ducts, each called hepatic ducts, left and right hepatic ducts, emerge from the liver. They fuse together and form a common hepatic duct. I guess that's not labeled here. We'll see that later. So bile is flowing in the direction of these dark green arrows, and they begin to flow down towards the GI tract itself. But if we're not in need of bile, if we're many hours past our last meal, that bile, instead of going onto the GI tract, is going to just go up this duct here to the gallbladder. And this duct that forms the connection between the gallbladder and the common hepatic duct is called the cystic duct. So that the cystic duct will lead bile into the gallbladder, and where it can, if it stays there long enough, it will be concentrated mostly by the epithelium of the gallbladder, just taking up or pumping water out of the bile. And there are, well, this gets a little ahead of things, but there are veins directly connecting the gallbladder to the liver, and that water that's taken out of the bile is returned to the veins of the liver. Okay, so once the bile is stored there long enough and we eat a meal and we need to begin to metabolize fat, the gallbladder will release bile, and the bile will then go down, exit the gallbladder, leave by way of the cystic duct, and go through the bile duct to the duodenum. So here, yeah, well, I'll get to that a little bit later. So that, I think that's a good overview of what's going on there. So let's take a look now at the pancreas. So we've talked about the pancreas in terms of being retroperitoneal. We know it's mobile, it's attached to the posterior abdominal wall. It has the exocrine and endocrine functions that we talked about. And then it has, it's this kind of, it almost looks like a fillet of fish here. It runs from the anatomical right to the left. And it's spoken of as having these four parts: a head, a neck, a body, and a tail. So the head is actually going to be over here on the right side. And the associations or relationships that mark the head of the pancreas would be its relationship to the duodenum. We talked about the duodenum as having four parts. There was a superior, descending, horizontal, and superior portion, or you can just say parts 1, 2, 3, 4. So they form this U-shaped structure, which is shown nicely here, and you see how that, or U-shaped is actually a C-shaped. So C-shaped structure, and that C surrounds the head of the pancreas. So this would be the head of the pancreas right here, it's the largest part. And then it begins to extend towards the left, and right here is something else that we talked about before. Look at how the origin of this, say, the superior mesenteric artery is just posterior to this region of the pancreas. So this region right here is usually thinner than the rest of the body over here to the right. This is the part referred to as the neck. And the important relationship there is the neck is just immediately anterior to the origin of the superior mesenteric artery coming off the aorta. Then we go to the left of that and we have this region of the body. And then somewhere, no real defined border, is the tail. And the tail actually projects into a region called the hilum of the spleen. We haven't talked about the spleen, but it's over here in the left upper quadrant. It has a diaphragmatic surface here, the lateral surface back here, right up against the diaphragm. And then this more medial region has a hilum where arteries, the splenic artery coming from the celiac trunk and shown right here, is actually going to enter the spleen. So this would be the tail over here associated with the spleen. So the next thing we'll talk about the duct. So I mentioned, the duct is going to be draining the exocrine product of the pancreas, not the endocrine product, but just the exocrine product, and that is primarily a group of digestive enzymes. So these things are going to be going on their way to the GI tract. And we can see shadowed in here, we start back here at the tail, you see a little bit of this main pancreatic duct right here. It is heading towards the right, and it is then going to come to be associated with the descending part of the duodenum, or the second part of the duodenum. And the duct is actually going to penetrate the wall of the duodenum. And if you look very closely right here, there's a little mound that the artist has put in there that's called the hepatopancreatic papilla. So it's a little mound of tissue. And of course, right at the tip of that mound, there's an opening, and that's where, in this case, the pancreatic juices are going to flow from the main pancreatic duct into the second part of the duodenum and begin their work. Okay. We can also see there is usually there is an accessory pancreatic duct, and when you study embryology, you'll hear about the development of the pancreas. It develops from two pancreatic buds that grow off of the foregut. They later fuse together, but each of those parts has a as a duct, so you end up with a main pancreatic duct and an accessory pancreatic duct. That's not the most important thing we'll be talking about today, but that's, you probably noticed that when you, here's the accessory pancreatic duct. The other thing that you will notice here is, if you look closely and follow the green shading here, here's that bile duct that's draining the liver and gallbladder. And you can see that that duct is actually going to join with the main pancreatic duct. And it creates a region called the hepatopancreatic ampulla. And here, so if we take this little square right here and magnify it and show it right here, we see here's the main pancreatic duct joining with the bile duct, and then it just makes sense that these two ducts forming together are going to form a bigger tube. And that bigger tube is going to be the hepatopancreatic ampulla. Ampulla just means bigger storage device. That ampulla is going to penetrate the duodenal wall and then open up on the tip of that hepatopancreatic, or the major duodenal papilla. And then the other thing that is shown here, these circles around the hepatopancreatic ampulla, the bile duct, and the main pancreatic duct. This is smooth muscle that's aggregated in this region, and they will actually form sphincters or valves that at appropriate times they can actually close off those tubes so that you don't have constant drainage of pancreatic juices into the duodenum or bile going into the duodenum, but that can be physiologically regulated. So this picture right here is just an artistic rendition of the inside surface of the duodenum here, where you actually see that major duodenal papilla right there. So, now the blood supply to the pancreas is a little bit involved. First of all, probably just thinking about this, you would realize the pancreas is growing off of the foregut, the foregut derivative. So you would think, okay, its blood supply is going to come from the celiac trunk, and that's true. So there, here is the dorsal aorta attached to the posterior abdominal wall. You see the pancreas and the four parts of the duodenum here. So we see the head of the pancreas, the neck of the pancreas, the body, and then the tail here. And here's the celiac trunk, the first of those three unpaired arteries that are going to supply the GI tract. And we talked about these branches. So it makes a splenic artery, a common hepatic artery, and a left gastric artery right here. But the splenic artery is following the dorsal border of the body of the pancreas, and there are numerous small arteries that go directly into the pancreas to supply the capillaries of the pancreas with arterial blood. But over here at the head of the pancreas, this large portion of the pancreas over here, the blood supply is not so straightforward. There are branches coming off of the common hepatic artery. You probably heard about these. I think you've been drilled on the arteries. This is the gastroduodenal artery. And a couple of its branches are called anterior and posterior pancreatico-duodenal. So these arteries over here are going to be supplying both the head of the pancreas and the duodenum. But what you wouldn't expect maybe is that there are inferior pancreatico-duodenal arteries also, and they are going to be derived from the superior mesenteric artery. So I guess the way I think about this is just the pancreas is a foregut derivative, but it's very close to the boundary between the foregut and the midgut, and just like the duodenum that gets a blood supply from both the celiac trunk and from branches of the superior mesenteric artery, the pancreas too is going to have branches supplied by the celiac trunk and branches supplied by the superior mesenteric artery. So here is where you can see an inferior pancreatico-duodenal artery forming a pretty complex and robust anastomosis with the branches of then the veins are going to basically just follow the pathway of the arteries, so there are going to be veins draining the tail and the body directly into the splenic vein, and then there will be pancreatic duodenal veins going either back to the common hepatic artery or directly to the superior mesenteric vein here. And then they will carry that blood to the portal vein and to the liver. So this is the way healthcare workers will often see these arteries. This is the way they'll do the anatomy. So in this case, a catheter has been introduced into the arterial system. It's been entered at the femoral artery and was passed up through the iliacs into the abdominal aorta and into the celiac trunk. And then a contrast agent was released. You can see the celiac trunk here. You don't really see the aorta, but you definitely see the common hepatic artery. And here goes the little branch in the superior, gastroduodenal, which then will give rise to the superior pancreatic duodenum. And here's the splenic artery. You don't see a lot of branches coming off of it, but this is where branches would be going directly into the body and tail of the pancreas. And I say here, estimate the location of the pancreas. So just looking at this diagram, you can see how this splenic artery is passing along the dorsal surface, or I guess maybe you say superior surface of the pancreas here. So the superior border of the pancreas would be about right here. Okay, any questions about this? Pretty straightforward. The next thing we will deal with is the liver. So this image is showing the movements of the liver as we breathe. So it's a pretty big organ. I think we had a slide that said it's like 2.5% of the entire body weight, but it's attached directly to the diaphragm. So when we take a big breath and the diaphragm contracts and moves inferiorly, the dome moves inferiorly, it's actually going to be pushing the liver ahead of it. So it can actually move 12 centimeters, about 6 inches. So even though, like at rest, most of the liver is protected by the thoracic cage, when we take a deep inspiration, the inferior margin of that liver is going to project below the rib cage and can actually be palpated there. So we'll want to look a little bit at the attachments of the liver to the diaphragm, and also see this big surface that most of the surface we're looking at here would be referred to as the diaphragmatic surface of the liver. So here is a medical image of the peritoneal cavity. We see the large liver right here, and here's a diagram looking at the same view. This will start over here. So here's the diaphragm right here, forming this dome over the liver. The spaces are a little bit exaggerated here, but right underneath the diaphragm would be the liver. And we talk about two surfaces, the diaphragmatic surface, and then this more inferior visceral surface, inferior surface or visceral surface. Visceral just referring to all the other organs that would be resting on it here, so like the intestine, the kidney, here's the right kidney. So, and then we also have these spaces around the liver. So in the image right here, you can kind of see where the diaphragm would be. You don't really see it right here. But if a surgeon was working in here and they had opened up the abdominal cavity, their hand could slip right over this surface right here into this space. This is the subphrenic space. So you can push your hand all the way back to where the peritoneum comes off of the liver, and we say it reflects onto the inferior surface of the diaphragm here. This ligament right here, or this attachment, is going to be referred to as a coronary ligament, attaching the liver directly to the inferior surface of the diaphragm. So the diaphragmatic surface ends at this sharp boundary inferiorly here. We call this the inferior border. And then, if you put your hand into this space, your hand would be going along the visceral surface of the liver. This is referred to as the subhepatic space. And this subhepatic space has this extension that goes, it's sometimes called Morrison's pouch, or here it's labeled more properly as the hepatorenal recess. So you push your hand. It's important because a bedridden patient that might have bleeding in the abdominal cavity or might be producing a lot of ascites fluid from, say, an infection, when they're lying down, this is where a lot of that fluid is going to accumulate. One of the deepest spots in the greater sac of the peritoneal cavity. But then the peritoneum will reflect off the liver just onto the posterior abdominal wall here. And so, and you can see this would be the hepatorenal recess right here. The bare area, you'll see that labeled right here. The bare area is this region of the liver right here that is not covered by visceral peritoneum. So you have these two reflections of the peritoneum onto the diaphragm here and inferiorly just onto the posterior abdominal wall, but the space in between is referred to as the bare area. Okay, so the other things that we see, well, first of all, let me continue with this, talking a little bit about the bare area. So the liver, this is the diaphragmatic surface that we're looking at right here. Here's the inferior border. The visceral surface would be down under here. We're just seeing a little bit of it. We see the gallbladder attached to the visceral surface. But the visceral peritoneum covering the liver is going to reflect off the liver right here. And this is what that coronary ligament is. The coronary ligament is the visceral peritoneum reflecting off of the liver and then attaching, of course, to the diaphragm, which we don't see in this, but we just cut the coronary ligament here so that we removed it from the diaphragm. The other thing that we see here is this large anterior structure called the falciform ligament. So the falciform ligament is actually going to attach the liver, not to the posterior abdominal wall, the way the mesentery proper attaches the small intestine to the posterior abdominal wall. The falciform ligament is going to attach the liver to the anterior abdominal wall. I'm just going to go to the next slide. Here we're looking at this same thing right here. We see the falciform ligament. And the first thing we'll note is it divides the liver into two lobes. Very simply here. There's a larger right hepatic lobe and a smaller left hepatic lobe, distinguished by the falciform ligament. These lobes are referred to as the anatomical lobes of the liver. And in a little bit, we'll distinguish those from the functional lobes. But here we have the falciform ligament. And then if we look at this picture, we've looked at this before, we know we're looking at the posterior surface of the anterior abdominal wall, and we can see the continuation of the falciform ligament right here. So in order to make this picture over here, what we did is just transect the falciform ligament right here in order to remove the liver. So the falciform ligament is this big, broad ligament attached directly to the anterior abdominal wall, but it has this free inferior border right here that has a ligament in it called the round ligament of the liver. Here you see that right here. This, in embryology, you'll learn that the umbilical vein, which is bringing oxygenated blood filled with nutrients from the placenta, is entering the fetus here at the umbilicus, and then that blood goes through the liver and to the heart. So if we follow the inferior margin of the falciform ligament here, we see it going down here to this region right here, which is basically the umbilicus or the belly button. So we won't go, I think you haven't been studying embryology, right? That's going to be later on, so I don't. Okay, so that is the falciform ligament. And we have the right and left anatomical lobes of the liver. Now, is that clear? Pretty clear to everybody? So, okay, let's take a closer closer look then at the structure of the liver itself. So this picture right here, we have to imagine that the subject it's facing away from you when you look at this. So this is the posterior aspect of the liver. This is the inferior vena cava, and there's a big notch for the inferior vena cava. The inferior vena cava is attached to the posterior abdominal wall. It's retroperitoneal. It's it's going to go through this fossa in the liver, this or groove, and then pass through the duodenum. So it's going to be going through the duodenum right here. So this is the posterior aspect of the liver. So what we're looking at is the visceral surface. So over here on the anatomical right, we see the gallbladder. It's attached directly to the liver at a place called the fossa for the gallbladder. Makes sense. And we see that there are a lot of other relationships with nearby organs that are reflected in this or shown in this. So if we look down here, we've opened up the anterior abdominal wall, and we can see some of that falciform ligament here. So we know we're to the left, the anatomical left. This is the left lobe, anatomical left lobe of the liver. And here we see that the visceral surface is labeled gastric impression, just because the left lobe of the liver, as we see here, has a relationship to the stomach, or gastric stomach impression. There's also the large intestine makes this colic impression right here. So the large intestine right here would be closely associated with the right lobe of the liver. But then, in addition to those two lobes, two anatomical lobes, I mentioned the right and left. They were very easy to distinguish. On the visceral surface, we have two smaller lobes. One is called the caudate lobe, and you see it right here between the inferior vena cava and this groove right here, which is referred to as a umbilical fissure. I'm not going to talk about the embryology. It's labeled here the fossa for the ductus venosus, and the ductus venosus has to do with in the fetus blood, oxygenated blood coming through the umbilical vein will bypass most of the liver capillaries by going through a duct right here. But this is this fissure and the inferior vena cava kind of give the lateral margins of this caudate lobe of the liver, this little lobe right here. And then anteriorly, between that same umbilical fissure and the gallbladder, there's this other little lobe right here called the quadrate lobe. So if we look now at diagrams of the inferior surface and just make this maybe a little bit more clear, we have, they're indicating two vertical fissures right here, a right sagittal fissure, and I guess you could call this a left sagittal fissure. I was referring to it as an umbilical fissure. So you have, in the fetus, you have an umbilical vein and a ductus venosus here over on the left side. So again, this person would be looking away from us in this diagram, and we're looking at the visceral surface. So the right lobe of the liver would be over here. Here's the smaller left lobe. But then we have this place in the middle that they're referring to as a porta hepatis. So what is a porta hepatis? So let's look at a more realistic drawing. We see more of the anatomy structures here. We see the gallbladder, which would be right here, gallbladder, and we see the inferior vena cava going through this groove on the posterior aspect of the liver. And here we have that round ligament of the liver. This was an adult. And the obliterated ductus venosus. It's called a ligamentum venosum in an adult liver. And then here in the middle, this is often referred to as an H. You see it better here. So you have these sagittal fissures that make the bars, the vertical parts of the H, and then this little imaginary line connecting the bars of the H right here. This region is referred to as the porta hepatis. So what this really is the hilum of the liver. So we know what a hilum is. We talked about that in the kidney. I think when you talked about the lungs, you talked about the hilum. That's just the doorway into and out of the organ. So the liver has a hilum, but instead of calling it a hilum, we call it a porta hepatis. So what is going in and out at the porta hepatis? So we know there are hepatic arteries, right, coming from the celiac trunk. They're going to enter, the arterial supply is going to enter there. We talked about the hepatic portal vein carrying blood from the GI tract. That portal vein is going to be entering the liver at the porta hepatis. And then we talked about the bile ducts carrying the bile from the liver out of the liver. Those ducts are going to exit at the porta hepatis. Together, those three things are referred to as the portal triad. We'll talk more about that in histology too, because you'll see that relationship, those three structures, those three tubes are going to be together even when you look at histology, like sections of the interior of the liver. Okay, so that is the porta hepatis, or portal triad. Here, this picture, this is kind of nice because we've taken away a large segment of the liver, dissected that away so that we can now look at the visceral surface of the liver and see the hepatic artery entering the porta hepatis, or the portal triad. They go in and immediately divide. The hepatic artery is going to immediately divide into a left and a right hepatic artery. The portal vein is also going to divide immediately into a left and right portal vein. And there are going to be two ducts bringing the bile out of the liver, a left and right hepatic duct. So these three vessels or channels are actually going to characterize what we refer to as left and right functional lobes of the liver. So the hepatic artery, if we just consider the hepatic artery, it's when it divides into a left and right hepatic artery, the left artery is going to fill the capillaries on the left side, or in the left functional lobe of the liver. The right hepatic artery is going to fill capillaries in the right functional lobe of the liver. And the functional lobes don't exactly correlate with the left and right anatomical lobes, which are characterized or demarcated by the attachment of the falciform ligament. So what happens is, here is, we're looking at a liver. In the falciform ligament, we have this large right anatomical lobe and a smaller left anatomical lobe. If we wanted to draw in the boundary between the right and left functional lobes of the liver, we could start at the gallbladder right here and draw a line like this that goes back and connects with the inferior vena cava. So a large portion of the right anatomical lobe is actually part of the left functional lobe. Okay, so the right functional lobe is still a little bit bigger than the left functional lobe, but they're more closely related in size than are the anatomical lobes. Okay, so now this is just a very busy structure, but I put that in. This is just the lungs up here. We're seeing the pulmonary vessels with this contrast agent, but down here in the abdominal cavity, we see this is where the liver would be, up here. Here would be the area of the porta hepatis, where the portal triad is being coming and going from the porta hepatis. This is actually the hepatic portal vein. You see the splenic vein here, and you see it kind of go here's the spleen over here, and you see the origins of the splenic vein coming over here, joining with the superior mesenteric vein, and then here goes the hepatic portal vein to the porta hepatis, and then here is the right portal vein and the left portal vein, each going to their respective functional lobes of the liver. Okay, so on the visceral surface of the liver, we saw this gallbladder, and I told you that it's attached, the gallbladder is attached directly to the liver. And it has this duct that is connecting it, the cystic duct, connecting it to the tubes that are draining bile from the liver. So at the porta hepatis, we see a right hepatic duct and a left hepatic duct. They come together to form this common hepatic duct, which then joins with the cystic duct to form the bile duct, or sometimes referred to as the common bile duct. That's going to go descend inferiorly. It's on its way to the second part of the duodenum. It goes posterior to the head of the pancreas, and then joins with the main pancreatic duct and exits or opens at the major duodenal papilla, where the bile can be released into the duodenum. So the gallbladder itself, it has the biggest part of it is the body. This is the body right here. It has a neck that is connected or directly continuous with the cystic duct, and then at the opposite end of the duct is this rounded end of it protruding from the inferior border of the liver. This is the fundus. So here's just an image, a medical image now, where they've used this a method called endoscopic retrograde cholangiography. So they've entered a catheter has been probably put down the mouth, gone through the stomach, into the duodenum, into the second part of the duodenum, to the opening of the major duodenal papilla, and then this contrast agent has been put into the ductwork and goes retrograde up this way. Let's start up here at the top. We're in the liver now. This would be the porta hepatis region, right about here. So we see the left and the right hepatic duct coming together to form a common hepatic duct. And then we see a little bit of the gallbladder right here, but look at the cystic duct. You would think it would just join the common hepatic duct right here, like it often does, but this one is very long. It's going to go down, all the way down here, we still see it. Now it finally joins with the common hepatic duct to form the bile duct. And then that's going to, I don't really see the major duodenal papilla, but that's where it's going to enter. The blood supply to the pancreas gets a lot of attention just because there's so much surgery that involves the gallbladder. And I've mentioned that, of course, the hepatic artery, the common hepatic artery, is a branch of the celiac trunk. It's going to change its name along the way. It's going to change its name from common hepatic artery to proper hepatic artery. And that is after when the common hepatic artery gives off the gastroduodenal artery, which goes off and supplies the stomach, the intestine, part of the head of the pancreas. Then we change the name of the common hepatic artery to hepatic artery proper. The hepatic artery proper then gives off a right hepatic artery and a left hepatic artery. Both of these enter the porta hepatis, supply the functional lobes of the liver. The right hepatic artery, though, gives off the cystic artery, which is the main arterial supply to the gallbladder. So in gallbladder surgery, and in past years, I've used a video showing laparoscopic removal of the gallbladder. It's pretty instructive and it's fun to watch, but when I tried to get it this year, it said I had to sign in and assure that I was more than 18 years old. And I didn't do that. I don't want to reveal my age. But I think I do have the link. Maybe tomorrow I'll give that link to you. Maybe you guys can figure out how to get it. But it was pretty fun to watch because the surgeon goes in and begins to dissect apart the lesser omentum, the free border of the lesser omentum where the portal triad is located. They look for the cystic duct and the common hepatic duct. These two ducts, along with the inferior border of the liver, create an anatomical landmark, the triangle of Callot, or cystohepatic triangle. And within that triangle is where the surgeon then will begin looking for a pulsating cystic artery. find that, they'll clean it off, they'll put ligatures around it, and then, transect it, tie it off, and then dissect the gallbladder off of the liver, because it's actually attached to the visceral surface of the liver. And, they use a cautery tool these days to then take that surface of the gallbladder off the liver, and at the same time cauterize the vessel so there's not a lot of bleeding. So I'm gonna save this, it's kind of a conceptual challenge. Some of the, I'm gonna talk about, portal venous, cable venous anastomoses, tomorrow, but we'll save that when we're fresher, and I'll give you a break here and let you go. And enjoy the rest of your day.